Welcome to another episode of the Life in Motion podcast. Our topic on this episode, PTs in the ED? Yes, really. How emergency departments with physical therapy services can better serve communities. Today our guest is Rebekah Griffith, a fellow PT, board certified specialist in neurology, working as a clinician, educator, and advocate for both the PT profession and her community. She is also a mom, chasing her lovely three children around with Benjamin, her husband of 19 years, in the beautiful state of Colorado. Ladies and gentlemen, welcome to the show, Rebekah Griffith.
Thank you. I'm happy to be here.
Would you care to enlighten us about your journey first, how you became, a physical therapist, what attracted you to the profession, and later on, how you saw that being an ED is something you wanted to be?
Sure. So originally I was going to be a lawyer. I was going to go to college in California. And then my dad ended up having some medical issues and it led to some below knee amputations. And that was still kind of a scary thing. But like at that time, I just felt like that time wasn't the right time to go away to college. And then during that time, I got engaged, and then I got a job working while my husband went to college, and then I was going to be a stockbroker, and I
Wow.
worked for Merrill Lynch, and then 9/11 happened, and Merrill Lynch was like, hey, we got to let a lot of people go. And at that point, I was just ready to go to college. So I went to college, and I had some knee surgeries of my own, and I thought, I want a job that I can really help people, where I'm not stuck sitting down all the time. Like the office wasn't a good fit for me. And how could I make a difference, but do it flexibly? And what also really attracted me, I guess, to the profession is the body's ability to heal itself. Sometimes other interventions are necessary, right? But like there's so much that your body can do for itself. And I truly feel like that's one of the coolest things about physical therapy. So then I went to PT school and actually started my career at Craig Hospital in Inglewood, specializing in brain and spinal cord injuries. But then after I had kids, I just wanted to look and see like what else was out there, did some outpatient orthopedics, ended up in acute care, which I thought I would hate it. I had been afraid of hospitals, never really wanted to visit anybody there, never wanted to was so afraid of bodily fluids. It was ridiculous. But a friend from PT school said, hey, I think you should come and work with me and see what you think. It's great if you have a family. It's a different part of your brain, kind of gets you out of a rut. And so I did. I applied to work at the University of Colorado Hospital, and I fell in love with acute care. It's just so much richer than I ever thought. And one year at CSM, I just stumbled across this little thing about PT in the emergency department. And I thought, well, that's pretty cool. And so I went and I learned more about that. And then I talked to some people at my work about that. And what we had been doing was going to the emergency department on an as needed basis.
Oh.
So if there was truly something like that, like they felt like they couldn't discharge the patient without them seeing a physical therapist or without some recommendations, then we would still go see that person. But it was very much like you're managing 2 floors. And, if you happen to get any pages from the emergency department, please go take care of that as well. So as our hospital continued to grow and change, the question was, how are we going to continue to serve this area? And is there more we could be doing? So after several years of kind of learning more and more about it and really diving into the ED toolkit on the APTA website and learning more about the literature, more about how to start a program, my colleagues and I went ahead and we started a pilot program in our emergency department, and that was 4 years ago, and I feel like we're kind of there to stay. So it's been a really interesting journey.
Wow, I mean, you go from somebody who is thinking about law or, making $1 zillion in the stock market, and then you become a therapist and you said, I'm going to hate the hospital. And then you end up, oh my goodness, I love this, right? So
yeah, I can't imagine leaving it. Like intensive care is so amazing. Acute care is so amazing. It's like really meeting people in their most vulnerable moment, especially in the emergency department.
Oh, I love that. I love that story, how sometimes wherever you are in your career, you shouldn't really automatically close off options because
Yes.
as the Griffith story, you may actually be called into something very different than you thought.
But isn't that the best part of being a physical therapist? That you can change jobs settings, locations, practice types without ever changing careers.
That's right. That's right. That variety, that all these different settings you can get into. I think that's awesome. I love in
Yeah.
your story how you weren't sure if you were gonna like it. Now you can't see yourself anywhere else. And I hope our colleagues all feel and will have that same spirit and that same passion for the profession like you do.
Mm-hmm. I hope so.
So so now it sounds like you and your colleagues sort of started the program. So you've really seen it go from its infancy now to a fully fleshed out. You have an ED. You have a physical therapist in ED now. Can you share any like war stories or anything that really sticks out to you after all these years? Because I understand if you watch any episode of medical dramas, the emergency room seems to be always have like thumping music and heartbeat, right? And that might be true maybe a small part of the time, but I'm sure there's also quiet and just as rewarding or interesting moments that you might be able to share with us.
Yeah, I would say that the day-to-day is not like necessarily all that exciting, right? Like, you might have a ton of patients, you might have no patients, people might be there for a sore throat, or they might be there because they were electrocuted. You never know. And I think that's one of the most exciting things is that it's unexpected. It's not like, well, I'm going to see 5 patients who had a total knee replacement this morning and then a shoulder this afternoon and things like that. Like truly it is the unexpected. So I love that you have to be prepared for anything that kind of comes through the door. But say maybe a typical day might involve a patient with low back pain who I say this all the time to my outpatient colleagues. You haven't treated acute low back pain until you've treated somebody that came in face down on a stretcher screaming with low back pain. Like that's acute low back pain. So you might see somebody with that. You might see somebody who just broke their ankle and they need some, and maybe they use a walker at baseline and now they're non-weight bearing. And is that really going to work? Can that person safely go home? And I had a patient the other day who needed to be non-weight bearing due to a pathologic fracture, and they hadn't consulted me on this patient. And I said, well, what's your plan for this person to go home? And they said, well, they have a wheelchair. I'm like, well, do they? Do they, for one, does it fit them? Do they have stairs? Do they know how to get in and out of it without putting any weight on it? Do they know how to position this extremity in the bed once they get home? Do they know how to get in and out of the car? Like, what's their fall risk? And so just having that conversation with the medical team is so enlightening because they're like, wow, I didn't think about that. I just asked if they had a wheelchair at home. So, you might see something like that, or you might see someone who has dizziness, and we're asked to kind of assess what's the differential here? Like, is this a peripheral vertigo? Is this not? Is this something we can impact while they're here today? Or do we need to truly do a bigger workup or send them somewhere else?
You touch on something interesting on this article I'm flashing on the screen now about how physical therapists in ED are really very helpful for acute low back pain, the rawest definition of acute back pain.
Yes.
BPPV, and is this something that a physical therapist will be able to do and help? Do we really need to escalate the imaging, or that might be unnecessary imaging, and having an expert like a PT will help, save cost and difficulty for the patient in the healthcare system, and gait training. Again, you advocating is it the right walker? Is it the right wheelchair? Is there a walker? Do they know how to use it? And these 3 things you talked about how the physical therapist can really help in the ED. I wanted to ask you though, as a physical therapist, and if you happen to have a student who's interested in what you're doing, what kind of traits or what kind of qualities do you think that are unique to ED physical therapists that you probably think they should have so that they can really thrive and prosper in the ED department?
I think that's a really good question. I give a lecture on ED physical therapy to our local PT schools, and that's always a question I ask the students, like, what skills do you feel like you would need to have to practice in this setting? And I think some of the main, the primary skill I would say is time management, stress management, differential diagnosis, because those patients may still be having an emergency. I always tell students, like, just because you have an order on this patient doesn't mean they're in the clear. It means we still don't necessarily know what's happening. So be prepared for anything. I've had way more exciting events in the emergency department than in the ICU. Everything in the ICU is so tightly controlled, but in the emergency department, it's still evolving. So just being prepared for that and being able to respond calmly, I think, is important. Also, you have to have a really intricate knowledge of how payer sources work, which I think is a commentary on our healthcare system. But I need to know what I can actually offer this patient. I can't say, hey, I'm going to send you to rehab and I'm going to get you a custom lightweight wheelchair if the patient doesn't have a home or any payer source. So like being creative, I think, in your discharge planning is important, but also in your treatment skills, because I don't have a squat rack. I don't have a modalities cart. I don't have a traction unit. I don't have, so many things. I have a very limited amount of space, a limited amount of time, and I just need to be able to do what I can with what I can carry.
Right. I was, reading some of the references about it, and, me as an outpatient therapist, I squinch my eyes a little bit if I don't have access to high-low bed, because the fixed bed's only for young PTs. And I read about my emergency department physical therapists. If they're in a hallway on a bed, they're like, okay, and they're dodging people.
Or if you're in a chair, like if we're evaluating your neck pain in a chair, like that's just what we can do. I mean, sometimes it's even like in the ophthalmology chair where that's the space that you have. Right. So you have to, we're great about trying to get people on gurneys and beds as much as possible, but you have to be flexible.
It's almost like the physical therapy version of battlefield medicine, because basically that's what it is. They're coming from all sorts of wonky, not great scenarios, and you're just trying to do your part.
Yeah, and there are physical therapists that even practice in those battlefield situations too, which I think is amazing. There are also physical therapists practicing in disaster relief scenarios. So that's another type of emergency physical therapy that's a much larger topic even than emergency department physical therapy.
I was reading more about this one, and somebody who probably has a lot of say in this is the administration and the emergency department physicians who run this. And what they said, which I thought was really interesting, was, they have to manage so much with a finite amount of resources and a finite amount of time. And what they really appreciate is that synergy between PTs and MDs, so they can work on scenarios that really they're needed more, and how you can help offload and take away some of that burdens off them. And that's a wonderful way of us physical therapists and MDs serving the community together.
Yeah, one of my favorite things about the emergency department is how collaborative it is and how inter and multidisciplinary it is. I mean, we work with physicians, residents, medical students, nurse practitioners, physician assistants, social workers, case managers, pharmacists. You'll even have like your security staff that's so important. Sometimes they have to be part of your treatment session. You have the behavioral health folks that are helping decide if patients are a danger to themselves or other people. And I think it wouldn't work without the team. And I love that we are treated as like the same level of team as everyone else. For example, I had a resident who wanted to do imaging on a patient with hip pain. And I said, hey, I feel like I should take a look at this first. Like, let's hold back and I'll let you know what I think. And he said, well, I was going to do the orthopedic assessment after the imaging. I said, let's just do it in the other order. Like, why are we doing that? And the attending just, kind of smiled and said, Dr. Griffith has some questions for you, and so we were just treated like as at the same level at the table. And what ended up happening was that I did evaluate the patient, and my assessment was that she had hip bursitis, and due to many contributing factors. And the resident was like, wow, like I didn't even think to check that. I just assumed there must have been something serious happening. And sometimes there is, and sometimes it's the opposite, and we're the ones advocating for the imaging. But we wouldn't be able to do that if we didn't have such good rapport and teamwork with the whole team.
I always like to say if you're a student of the human body and all the things that are going right or can go wrong with it, there is so much work to do. There's so much work to do.
Yes.
And they've done the studies where they've seen the MDs. They don't really have as much of the musculoskeletal background as you would think they would have. And I always say having folks like us around, like another pair of eyes,
is can only help the patient. And it's just a matter of just that
Yes.
collaboration and that, shall we say, the turf war sometimes just has to be like really managed very carefully at a political and personal level.
But I think emergency providers are different in that their whole life is consulting other people, right? Like they're the gatekeepers of emergency. They help narrow it down, but then they may consult neurosurgery, they may consult general surgery, they may need to, call in a nephrologist. Like they're not afraid to ask people for their opinion, and then they take that and they take it in and they make the best decisions that they can for their patient. But their job really is stabilize and refer. And if they can do that now, they're all about it. So I've just been blown away by the kindness and the acceptingness of the ED providers and how willing they are to take our knowledge and use it as a tool.
Sometimes I guess for our colleagues, it's also helpful to understand it wasn't there before you and your colleagues asked about it. Sometimes a little boldness is asked from us physical therapists to just look around and ask, how can we be of service to you and your patients to get better outcomes? Because, we're here to make the job easier.
Yes. And we did a provider satisfaction survey, and 92% of the providers strongly agreed that we helped them take better care of their patients, and 8% agreed. Nobody was neutral. Nobody disagreed. Everyone was on board. And I saw a tweet the other day from an emergency physician, referring that he had consulted his emergency physical therapist. And this other ED provider just wrote back and said, "You have a physical therapist in the emergency department? What kind of utopia is that?" And I just thought, that is so cool that if we could really support these teams to the best of our ability, everyone would get a little bit easier of a job and every patient would get really what they needed.
Now, the APTA, since this is such an emerging field, would you know if the APTA has any position statements or any particular stances on how physical therapists can help in the emergency department?
Well, I would just back up and say that emergency physical therapy has been around in the United States for well over 15 years. There are some amazing pioneers who have been at this for a really long time. There's too many of them to list, but the founding PTs of this area are just remarkable people. And the APTA has been supportive through that whole process. For example, I referenced earlier that there's an emergency department toolkit on the APTA website that was created by a bunch of volunteers, and the APTA House of Delegates also was in support of promoting emergency physical therapist practice for many years. However, in exciting news, this year at the House of Delegates, we were actually able to pass 2 motions in support of emergency physical therapist practice. And the first one is really truly recognizing what emergency physical therapist practice is and what kinds of settings that might be in, and defining it as a practice area so that students can learn more. Other physical therapists, other health professionals, like the AMA can come in and say, "Hey, we've heard about this. What's your thought about that?" And so the APTA now has a position statement about what an emergency physical therapist is. And then the second was truly a charge to the APTA to help us develop and promote this field, as well as identify and remove barriers. And so I couldn't be more excited about that. I think it was a really exciting time to be at the House, even though it was virtual this year. And I hope that we'll see good things going forward. I know already they're working to revise the toolkit just to update it from when it was created with more recent literature, more recent practice patterns, that kind of thing. So it's really exciting.
It sounds like the future looks very promising for physical therapists in the emergency department.
Yes.
For our future colleagues, for our students, or for our current colleagues who are currently in the profession, I'm going to flash the resources you were saying about on the APTA about the emergency department toolkit right here. But if they want to know more, if they want to maybe reach out to you, would they have a way to reach out to you on the various social media networks, or just to mentor off you or the people who could show the way?
Absolutely. So what I would most recommend is the Emergency Physical Therapist Facebook page. It's the EPT page on Facebook, and you will find all the pioneers of EPT there. You'll find people who are developing programs. You'll find people like myself who are still relatively new to the game but really excited about it. There's also a complimentary student page. So there's an EPT student page as well. And if you're on a rotation in the emergency department, we'd love to have you help facilitate that page. So that's a really great place. Plus, you can search for the hashtag EPT on Twitter as well, and you'll find some good resources. And then my Twitter, I think, is rgriffithdpt. And I'm happy to have people reach out to me there as well. And it's super exciting. I'm happy to talk to anybody who will listen about it. And we also at CSM have a meeting every year as part of the Emergency Physical Therapist Folks Group.
Oh, thank you so much. Oh, this has been such a great conversation. I love how we learn more about how, yes, ETs and ED and how we can be of tremendous benefit to society and community. So once again, everybody, would like to thank Dr. Rebekah Griffith for her time spending, and sharing her knowledge with us so that we can learn more about this emerging practice. And we hope we have more of you colleagues serving like her in emergency departments across the country soon. Thank you so much, Dr.
Thank you.
Thank you for listening today to the Life in Motion podcast. Striving for excellence doesn't demand perfection. Just be a little better in all that we do than yesterday. This is Ben Aguila. Till our next episode. God bless.